वही गूंजती आवाज।
Dr. Lokesh, shall we start?
Yeah.
Good morning, everyone. I, Dr. Neha Chauhan,
Good
on behalf
morning,
of
ma'am.
School of Paramedical Sciences, Sri Guru Ram Rai University, welcomes you all to the national webinar entitled Advancement in Disease Diagnosis and Treatment. The webinar is designed to develop the understanding of various advancements made in the field of medical sciences to combat diseases with appropriate diagnosis. It is a privilege to organize a platform to instill curiosity driven attainment of knowledge by welcoming our eminent keynote speakers. Speakers of the session are Dr. Priyanka Verma Soni, Consultant, Nuclear Medicine, Radiation Medicine Center, Bhabha Atomic Research Center, Mumbai. Dr. Pramod Kumar Gupta, Scientific Officer E, Tuberculosis, Immunology and Immunoassay Development Section, Radiation Medicine Center, Bhabha Atomic Research Center, Mumbai. It is my privilege to introduce Sri Guru Ram Rai University, a leading university of North India, imparting education in various streams with its motto, Quest of Excellence. Sri Guru Ram Rai University is founded by Sri Mahendra Devendra Das Ji Maharaj in 2017 to serve the purpose of Sri Guru Ram Rai Education Mission. Presently, university runs Sri Mahend Indresh Hospital, a 2,000-bedded multi-speciality and super speciality hospital, College of Paramedical Sciences, College of Nursing, School of Basic and Applied Sciences, School of Management, School of CA and IT, School of Pharmacy, School of Agricultural Sciences, School of Humanities as its constituents. Before beginning with the program, I would like to thank Honorable Chancellor Sir Sri Mahendra Devendra Das Ji Maharaj for his blessings throughout. The chairman of the mission, Sri Mahendra Devendra Das Ji Maharaj, added new dimensions to the social service and pursuit of it by starting Sri Mahend Indresh Hospital, Sri Guru Ram Rai Institute of Medical and Health Sciences, College of Nursing and College of Paramedical Sciences. Sri Mahend Indresh Hospital and all these institutions are epitome of excellence of academic and quality healthcare, respectively, and catering the populace of Uttarakhand and its neighboring states. Many national and international awards have been conferred on Sri Mahendra Devendra Das Ji Maharaj. To name a few are Swami Vivekanand National Award, Shiksha Bharati Award, Rajiv Gandhi Excellence Award, Asia Pacific International Award, and Dr. Shivanand Memorial Award in recognition for exemplary contribution of Sri Guru Ram Rai Education Mission towards nation building under the leadership of His Holiness. With these words, again, I would like to express my gratitude towards Honorable Chancellor Sir Sri Mahendra Devendra Das Ji Maharaj for his blessings, motivation, and encouragement. Now, I welcome our Honorable Vice Chancellor Sir, Professor Dr. U.S. Rawat. I would like to give a brief introduction to Sir. Sir has 39 years of experience in management and 13 years of research experience. Sir has served in various government organizations at highest positions and capacities, to name a few. Chairman, Selection Committee for Guest Faculties in the various degree and postgraduate colleges of Uttarakhand. Assistant Director, Entomology in Union Ministry of Agriculture, Directorate of Plant Protection, Quarantine and Storage, and posted at Central Integrated Pest Management Center, Solan HP. Deputy Registrar, Banaras Hindu University, later elevated to the post of Joint Registrar. Registrar, Baba Saheb Bhim Rao Ambedkar, Central University, Lucknow. First Registrar of newly converted Central University from the State University, that is Hemvati Nandan Bahuguna Garhwal University, Srinagar. Former Vice Chancellor, Uttarakhand Technical University, Dehradun. Former Vice Chancellor Hemwati Nandan, Bahuguna, Uttarakhand Medical Education University. Former Vice Chancellor, newly established Shri Dev Suman, Uttarakhand University, Badshahit Hall, Tihri, Garhwal. Presently, Sir is serving as Vice Chancellor, Shri Guru Ram Rai University, Dehradun. Sir has started his career and reached the highest milestone in academic and administrative services. Sir has published over 56 research papers in various leading national and international journals and 7 books on different topics. And his latest book entitled Uttarakhand Contemporary Issues of Climate Change and Development with a Holistic Approach was released by Honorable Governor at Raj Bhavan, Dehradun. His another book entitled Himalayas, Ecology, Resources, Development and Conflict, recently released by Honorable HRD Minister Dr. Ramesh Pokhriyal Nishank, got appreciation from the intellectual fraternity all over the country. Sir has been honored with several awards. Some of them are International Award by American Biological Institute, Leadership Award, Vijay Shri Award, Samaj Shri Award, Uttarakhand Gomukh Award, Uttarakhand Ratan Award, Shri Dev Suman Award. Sir has also been felicitated by 12 Gram Panchayat of Tehsil Joshimath for his outstanding contribution in the field of higher education. For official beginning of the webinar, I would like to request Sir to please motivate us with his valuable words. Sir, please.
Thank you, Dr. Neha Chauhan. Very good morning to all of you.
Good morning, sir.
Good morning, sir.
Sir.
Good morning, sir.
Sri Mahant Devandas Ji Maharaj, the Dean, School of Paramedical Studies, convener, who is happened to be convener also, co-convener Dr. Neha Chauhan, organizing secretary Mrs. Mukesh Chamoli, then organizing coordinator Mrs. Divya Chauhan, and above all, our more revered and respectable keynote speaker of today's webinar, Dr. Pramod Kumar Gupta, Scientific Officer, E. Radiation Medicine Center, Bhava Research Institute, Mumbai. Another keynote speaker, Dr. Priyanka Verma, Radiation Medicine Center, Bhava Atomic Research Center, Mumbai. Respected HODs, faculty members, dear students, research scholars, ladies and gentlemen, indeed, it is a matter of great pride and pleasure to me to be a part of this webinar. And the theme and topic of this seminar is very relevant in the present context, when the whole world is suffering from the COVID-19 pandemic. And India is not alone. India has suffered a lot in terms of the human losses. Our economy has fallen down. Colleges and institutions are still closed. Business impact is also there. So many adverse effects has been seen on the various aspects of our life. And therefore, the advancement in disease diagnosis and treatment is having some relevant meaning in the present context, as I told earlier. As we are aware that Guru Ram Rai University is established during the year 2017. We have just completed 3 years. But in the field of medical and research and health sciences, we have been working for the last 10 years. And we are very fortunate that we are having the Institute of Medical Sciences, working in collaboration with the paramedical sciences as well as the nursing sciences. What I mean to say that integrated approach for the improvement health sciences of the as well as the health of the human being is a very important in the present context. And our institution, like institutions of health and medical sciences, in collaboration with the paramedical sciences and nursing sciences, are playing a very vital role, especially with reference to the Uttarakhand population. And therefore, I can say that the relevant topic is having the more meaning in terms of the responsibilities of our scientists, of our faculty members who have been engaged in the medical fields. Friends, let me recall some developmental in the field of science and technology as I am working in the field of higher education for the last 40 years. The medical sciences or biological sciences has made a very tremendous, significant achievement in the past few decades. If you go history long back, 1960 and 50 like that, there were so many problems. So with the advancement of the new techniques and correct diagnosis, we have been able to control some communicable diseases, especially like plague, cholera, hyja, so many tuberculosis. But still, in Uttarakhand, some new diseases is emerging day by day, and some communicative diseases like tuberculosis. The very few examples we have seen in Uttarakhand. So what I mean to say that science has made a very tremendous and significant achievement to control some very, you can say that, communicable diseases. As a result, the health improvement we have seen of the general people in Uttarakhand, not only in Uttarakhand but all over the country. Environmental changes has to play very significant roles on the human being, and prevention is better than cure, as we all know that. With the advancement of the knowledge, with the advancement of the education, the awareness came into the mind of human being. As a result, certain kind of precautions we have taken. We are thankful that our history, if you go back long 19 or 16 era, 1629 or 28, then the discovery of the blood circulation made by the William Harvey. And after that, there were 6 achievements we have seen. The Darwin theory, we have seen that evolution of the life, how the life came into the existence in the world or on the earth. How the significant achievements have been made from unicellular to multicellular, from non-vertebrate to vertebrate. So Darwin's, we are thankful to the Darwin theory, who have made some kind of race for the evolution of the history of the human being. Similarly, if go back that in the field of genetic sciences, Darwin theory has played a very important role in the history of the cell biology as well as genetic biological structure. What I mean to say that the development in the field of science and technology came along with the development of the correct diagnosis and experiments. Louis Pasteur and Robert Koch, that they founded by microbiology, and after that, the development of physiology and biochemistry we have seen step by step. With the birth of cell theory, modern pathology was established, and as a result, so many areas we have touched, our scientists have touched in the field of pathology also. Then the microbiology has to play a very significant role for the identification of some kind of constants which are available in our body. What are the deficiencies, where the numbers are increasing in so many areas. What I mean to say that microbiology, biochemistry, physiology, all have to work together in an integrated manner, and only then we can have some kind of very correct diagnosis. If you see the history that earlier, there were no some kind of instrument for the measurement of the blood pressure like that, or even the heartbeat. Now the discovery of blood measuring instrument as well as the stethoscope, they came into the existence, and now it is easier to our doctors, scientists to make the measurement of the blood pressure. But I mean to say that slow and steady the human have made the very significant in the field of discovery of some kind of instrument also. The whole idea of this webinar is that until or unless we are having the very diagnosis and we are having the very sophisticated equipment, then it is very difficult to exact position of that particular disease. Science has made the tremendous, remarkable achievement. Our medical sciences also facing the lot of challenges in terms of the new invention of so many diseases. For example, the discovery of X-rays, then ultrasound machine, now MRI machine. The sophisticated and high resolution power of this MRI machine also, different kind of MRI machine are also being invented day by day. They have been upgraded day by day for the cause of the correct identification of the some kind of very serious diseases. Similarly, for the identification of the cancer, etc., the new invention is being made day by day. And there are so many challenges before the scientists and medical scholars also. How we have to face the challenges? It is with the help of correct diagnosis and new invention and innovative and creative ideas of the human being also. And therefore, I can say that integrated approach in the field of medical sciences is very, very essential for the correct diagnosis of the particular type of diseases, and after that to make the some kind of realistic description for the procurement of that particular disease. I think that the webinar which our Department of Paramedical Sciences is organizing, it has to play very significant role in the life of the human being, as well as in the field of the science and technology, particularly with reference to the medical sciences and paramedical sciences. The responsibilities of our faculty members also has been increasing day by day. The reason is that if you see the particular reference of the Uttarakhand, there were some diseases earlier, they were very common, but now it is curable. And as a result, some new diseases is emerging day by day. The cancer is one of these very serious diseases, is being located in Uttarakhand. Maybe the smoke cancers, pancreatic cancers, throat cancers, skin cancers like that. So many types of the cancers we have seen in Uttarakhand. Earlier, there were very few cases were there, and it was assumed that generally the cancer is being happened in the ages. But now the scenario totally has been changed. Even the young generation, young people, they are affected, they are found, they are suffering from the cancer diseases. Similarly, the tuberculosis was the one of the very serious diseases in Uttarakhand earlier because of the so many problems, malnutrition, non-proper hygienic conditions, environmental conditions like that. But it is curable in Uttarakhand. Even then, it is found in a sporadic manner, isolated manner here and there. But it is not a serious problem in Uttarakhand. It is curable now. But cancer is going to be increasing day by day in Uttarakhand. And smoking, one of the very bad habit. Consumption of alcohol is also bad habit in Uttarakhand. And I hope that the environmental conditions, the food habits, it has to play the very significant role to prevent the cancer diseases. Therefore, this is the duty of our paramedical staffs and medical sciences also to educate, to disseminate the knowledge in a correct and effective manner to the common people of the society. Invention of the new equipment, correct diagnosis, along with the integrated approach in the field of medical sciences has to play the very significant role for the improvement, the health condition of the human being in the society. And therefore, on this particular occasion, I must congratulate to the faculty members for having such type of webinar, which is very relevant for the improvement of the health of the people. And ultimately, the keynote speakers who have been invited from the Bhabha Atomic Research Center, Bombay, their knowledge will be very beneficial. Their information will be very beneficial to the faculty members, to the research scholars, to the other scientists who have been associated with this webinar today. I hope that by virtue of their experience, we can see that what kind of diagnosis method, what kind of advancement is being made in the field of diagnosis of the diseases. It will be learned by this gathering from our experts. And certainly that such type of information will be very beneficial, very fruitful, very informative to the research scholar, to the faculty, as well as to the common people of the country. With these words, I wish that this webinar will be very successful, very fruitful, and best wishes to all of you. Thank you very much.
Thank you so much, sir, for the knowledgeable speech and words of motivation and encouragement for our department. Thank you so much, sir. Now, I would like to welcome Dr. Lokesh Gambhir, Dean College of Paramedical Sciences and convener of the webinar. Sir has 10 years of experience in academics and research in the field of biotechnology. Sir's area of specialization is immunology. Sir has keen interest in research, as Sir has published a number of research papers in national and international journals and has presented papers and posters in various conferences and seminars. So with these words, I would like to invite Sir to say a few words. Sir.
Thank you, Dr. Neha Chauhan. Thank you for a fine introduction. With the blessings and continuous encouragement of our Honorable Chancellor, Devendra Maharaj, with the persistent motivation and unconditional support by our guest of honor, Honorable Vice Chancellor, Sir, Professor Dr. U.S. Rawat, Sir, I, on behalf of School of Paramedical Sciences, welcome you all the respected dignitaries and the participants to the one-day webinar on advancement in disease diagnosis and treatment. The year 2020 has been a year that would be remembered for decades to come. The year has shaken the foundation of human civilization. On the other hand, it has taught us many things. It has taught us how to thrive under adverse circumstances, how pivotal is the healthcare system, how important is the diagnosis and treatment of diseases. It has also taught us the importance of the digital platform in exchanging the intellect, the need to have continuous effort in providing holistic grooming to the young minds we cater in the universities, with the aim to provide a platform of attaining exposure of eminence outside four corners of the classroom. I welcome our keynote speakers, Dr. Priyanka Verma ma'am, consultant, Nuclear Medicine, Radiation Medicine Center, Bhabha Atomic Research Center, Mumbai. And I also extend my humble welcome to Dr. Pramod Gupta, Scientific Officer E, Radiation Medicine Center, Bhabha Atomic Research Center, Mumbai, to the webinar. We are eagerly waiting to hear from your side. So without taking much of the time, I would like to request the organizing committee and the coordinators to take the proceedings ahead. Over to you, ma'am.
I would like to thank the organizers and Dr. Lokesh, the School of Paramedical Sciences, for giving me this opportunity.
Thank you, Dr. Neha. Thank you, Dr. Neha. Good morning to all of you. I, Razia Siddiqui, working as Assistant Professor in the Department of Medical Microbiology and Organizing Coordinator of Webinar, welcomes you all on behalf of School of Paramedical Sciences, Shri Guru Ram Rai University. Thank you for joining us for today's webinar. Let's begin with the session. Our first speaker is Dr. Priyanka Verma Soni, working as consultant in Radiation Medicine Center, Bhabha Atomic Research Center, Mumbai. Ma'am is working in the field of nuclear medicine in various institutions since June 2007 and also mentoring number of MD students. Along with that, ma'am is also working on a wide variety of general nuclear medicine, spectropet CT. Ma'am has been actively participating in research as she has published numerous research papers in national and international journals and has presented paper and poster in conference and seminars. Now, I would like to invite Dr. Priyanka Verma ma'am. She will explain about the topic, exploring the PET, FTG and beyond. Ma'am, you may please start the session.
Okay. Thank you for giving me this opportunity. I would like to share my screen now. I hope I'm audible and the screen is visible.
Ma'am?
So the topic, yeah, Yeah, I will start now. So the topic is PET CT, FDG, and beyond. Now we all are quite familiar with the PET CT, which forms an integral part of imaging when the patients come for oncology as well as non-oncology indications. So today I'll be telling the basics of the FDG PET CT and also the advancements which are made in the field of radiopharmaceuticals and also in the field of imaging like PET MRI for this imaging. Now, what we know is molecular imaging is the in vivo characterization and measurement of biological processes at cellular and molecular level. So, as we see, PET is a form of molecular imaging. So, it assesses the physiology and the function. So, that is why, since it assesses the function, the changes occur before any change in the anatomy. So, before any radiological imaging modality picks up the PET, picks up the findings, and so it helps in the early diagnosis. So PET and CT. PET gives us the function or the molecular imaging, and the CT provides us the form, which is the anatomical imaging. So when we combine these together, like I describe it as the where form meets function. So it's a very useful modality where we can assess both. So what we do in PET CT is that we assess the tumor biology. So we can assess the physiology and biochemistry of the tumor rather than the anatomy. So that is why the detection is very sensitive. So we come to know whether the cells are functional, whether the cells are dividing very fast, because when we give FDG, that's a glucose analog. So if the cells are dividing very fast, they pick up FDG and we see it on the scan. So that is why we come to know whether how is the physiology and how is the biochemistry. Like if the cells are secreting some hormones, then we can assess that also, like using different radiopharmaceuticals, of course. And then if the cells are expressing some receptors, so there are ways of doing receptor imaging also. There are various kind of PET tracers. The tracers are the things which we inject into the patient, into the vein of the patient, and then we take the patient for the scan. So now these tracers, after we inject it into the vein of the patient, then it goes and localizes into the specific cells. So those cells can be, if we are studying any oncology indication, then the cells, this FDG will go to the multiplying cells. So the cancer cells have a very high rate of multiplication, around 10 times more than the normal cells. So this FDG goes and localizes in those cells. So the glucose requirement of those cells, malignant cells, is much more. So this FDG forms the workhorse of PET. That means that the most of the PET which is done all over the world is usually FDG PET. So but based on metabolism, other than glucose metabolism, there can be other tracers also. Like for bone metabolism, we have F18 fluoride. Then for lipid metabolism, lipid synthesis, we have C11 acetate, F11 choline. For amino acid, we have C11 methionine and F18 tyrosine. Then apart from metabolism, we have perfusion tracers, which tell us the blood flow to certain organs. Usually it is used for heart imaging, for myocardial blood flow evaluation. So those are O15 water, N13 ammonia, or rubidium 82, but these are not so widely available. Then we can also assess DNA synthesis, like how fast the cells are proliferating, the nucleus is proliferating. So that will be done by F18 fluorothymidine or C11 thymidine. Then the receptor expression also we can check among the cells. So in that, what kind of receptors we can check? Those are the somatostatin receptors, which are usually present in the neuroendocrine cells. And so we can assess the neuroendocrine tumors using these gallium dotatate, gallium dotatalk, and dotanok. Then estrogen receptors, these are usually there on the breast cancer cells. Then dopamine receptors, which are again there in the neuroendocrine tumors. Then benzodiazepine cells, like it helps us in the diagnosis of epilepsy. Then hypoxia imaging can be done. So in the tumor, many times it happens that in the center of the tumor where there is necrosis and all, it can lead to hypoxia. There is low level of oxygen. So in that area, the radiation therapy will not be that much effective. So if we do this hypoxia imaging by injecting F18 meso or this copper 64 ATSM, what we can find out is where is that hypoxia region, and then the radiation therapy doctors, they can increase the dose of the radiation which has to be delivered to that area. So then their radiation therapy will be more effective. So it helps in the radiation therapy planning. Then we can also assess angiogenesis. So usually in the tumor cells or even in other inflammatory cells, there is lot of neovasculature. That is not lot of angiogenesis. Lot of small blood vessels are formed. So new blood vessels are formed. So that we can assess by using this gallium-68 RGD. So at RMC also we are using a very wide variety of radiopharmaceuticals for PET imaging. First obviously is the F18 FDG, which we saw it is the workhorse, and I'll be telling you all the indications in detail. These are the other ones, which are the F18 fluoride for bone, then F18 FLT. This is for proliferation in the cancers. It can be used. Then F18 meso, which is for hypoxia. I told you it can be used in radiation therapy planning. Then F18 FET, which is usually used in detecting the brain tumors and the recurrence of brain tumors. Then gallium dotatate, which is very useful for the neuroendocrine tumors. It checks the receptor binding of somatostatin receptors. Then gallium PSMA, that is for the receptor binding of the PSMA in the prostate cancers. So this dotatate and PSMA also I will be telling you in detail, and fluoride also. So first we come to the FDG, which is the main radiopharmaceutical. What we do is we inject this F18 FDG. So F18 means F18 is the part which is the radioisotope, and then this FDG is the part which is the pharmaceutical. And it is so how it is made is that it is made in the cyclotron, and then it's actually a glucose analog. So in that the glucose group, the hydroxyl group is replaced by the F18, fluorine 18, which is a radioisotope. So that makes this whole compound a radioactive compound, and so we can see where it goes. So and what happens when we inject it? It is phosphorylated, and then after phosphorylation, after going inside the cell, it gets trapped. So here we can see that we inject the F18 in the vessel, that is in the vein, and then it goes inside the cell by the means of GLUT1 receptors, which is the same for the glucose also. So then after going inside the cells, it becomes phosphorylated, and by hexokinase enzyme, it becomes fluorodeoxyphosphate. And then, but then it gets trapped. It cannot undergo any further metabolism. So it gets trapped inside the cells, and it doesn't undergo the same metabolism as the normal glucose. So when this gets trapped inside the cells, we can do imaging and we can see where all it goes. We have already seen that malignant cells, that is the cancer cells, demonstrate a high accumulation. Now that happens because they divide very rapidly, and also they have increased cell membrane transporters, those GLUT transporters, they have more number of those transporters. And under expression of glucose 6-phosphatase, this means this is the enzyme which can actually degrade this F18 FDG, but that they don't have that much. That is why the accumulation of FDG is more in the malignant cells. So now what we get is the more accumulation of FDG in the cancer cells, so there is high tumor to background ratio. So background means there will be less FDG uptake, and in the malignant cells there will be more FDG uptake. So we will be able to differentiate the malignant from the benign lesions. So we need to know a little bit of the physics, that how it happens and how we can detect these rays. For that, F18 is a positron emitter. Now what that means is that when it's a radioisotope, and when it decays, it emits a positron, which is a positive electron, E+. So it's the nucleus emits a positron, and then as it comes out of the nucleus, then it encounters an electron after coming out of the nucleus. Now this positron and the electron, they combine together and they annihilate, like they get destroyed. So when they annihilate, they emit two photons which have the energy of 511 keV, and then these photons are emitted at 180 degrees and simultaneously, like in the opposite direction, they are emitted simultaneously. So now we know when the positron is emitted, at the same time this 180 degree, two 511 keV photons will be emitted. So these photons can be detected by the detector, which we can see here. So when we can detect them by the detector, at the same time, that is registered by this camera. This is a PET-CT camera which has a gantry. So this registers those 511 keV photons, and then we can come to know that, okay, from this cell, the positron has been emitted, and then we can, on the image, we can see that, okay, from these cells, the positron is being emitted. That means F18 FDG is going and accumulating in these cells. So the lesion is there in those cells. So coming to the imaging protocol, usually for FDG, what we want is the patient has to fast for around 4 to 6 hours prior to the study, prior to the examination. Then we do the injection tracer. Now the amount of tracer that we inject depends a lot on which kind of machine we have and all, and also the weight. So usually what we inject over here is around 5 to 6 millicurie we inject, and then we start the scan around 45 to 60 minutes later. We take a CT and then a PET. The whole body PET might take around 20 minutes. If we want to do only a regional study for brain or heart, it might take around 10 minutes. So this is the PET machine. And then now we need to know, before knowing that where the abnormal uptake is, we need to know where all there can be a normal or physiological uptake. So these are all the areas where the normal uptake will be. So that is the brain. Brain has a very high normal FDG uptake. Then the heart, the kidney, liver, skeletal and smooth muscle. If the patient is has been exercising or working, then the larynx and all, if the patient is speaking. Then in the thymus in the children. So where all there is high activity in the body, there all the uptake will be there. Physiological uptake will be there. Sometimes in thyroid there can be uptake, but that is not exactly physiological. That is due to inflammation in thyroiditis and Graves' disease. So this is an image showing where all there can be normal or physiological uptake. Now this FDG is excreted by the kidneys. So after we inject, it goes into the blood pool, it goes to the abnormal cells, the malignant cells, inflammatory cells, and the rest of it is excreted by the kidneys in the urine. So obviously the kidney, urinary bladder and the urethra will be showing the physiological uptake. Then how do we interpret the images? It happens that we can interpret it either qualitatively and also quantitatively. Qualitative means we just look at the image, see, okay, this is physiological, this is abnormal, and then we can come to know that, okay, this is the lesion. So wherever it should not, the uptake should not have been there, it's not a physiological uptake, those are usually the abnormal uptakes. So that is visual interpretation, that is qualitative interpretation. Then quantification can be done using values like SUV. SUV is the most commonly used value for quantitative interpretation of the PET data, and that measures the concentration of the F18 FDG in the area of that lesion. And so this is the formula. So basically what it measures is that how much F18 FDG is accumulated in those cells or in that lesion. So how many photons are coming from that region. Now coming to the applications, it has a wide variety of applications which can be oncological and also non-oncological. So here we are speaking only about the FDG. So PET with FDG imaging, it allows the direct evaluation of the cellular glucose metabolism. See, we saw that it is a glucose analog. So here we will assess only the glucose metabolism. So it has a wide variety of applications in neurology, cardiology, and oncology and pharmaceutical uses. So in oncology, what all can be done? There can be detection and staging of the tumor, then recurrence and restaging of the cancer, monitoring response to the treatment, follow-up evaluation, then PET-CT based radiotherapy planning, PET-CT guided biopsies can be performed, and also to look for unknown primary tumor presenting as metastasis. So initially what happens when the patient of any cancer presents to us, then we have to do the detection and the staging, that where is the tumor and what is the stage. So for that, the PET CT can be done to look for where all exactly it has spread. Then recurrence means the patient has been given treatment, but then again the tumor has come back. So we need to detect where exactly it has come back, whether it is really malignant or not. So that will be a restaging. Then if we do a baseline scan at staging, and then we give some chemotherapy or some radiation therapy, and then we do the scan again. So that will be a monitoring the treatment response. So then we'll come to know, okay, how much the tumor has responded to the chemotherapy that we have given. Then follow-up evaluation. After the patient has finished all the treatment, and then we have called the patient for a follow-up after 6 months or 1 year or something like that. We can do a follow-up evaluation that everything is fine, or still is there any residual disease over there, or if the tumor has recurred. Then I already told you that PET CT based radiotherapy planning can be done. So PET CT will help you to know exactly where all the active tumor is there, and not the necrotic and other edema. So the necrotic and the edematous tissue can be avoided, and only the active tumor, which is using having high glucose metabolism, can be given radiotherapy. And PET CT guided biopsy can be done. That means that if there is a tumor, you can obviously see it on morphological imaging like CT, MRI also, but sometimes it may happen that inside there is necrosis. So when we guide a biopsy, we put a needle inside. That means that we will take some tissue from there and see it in the pathology slides. So we need to have a good active tumor whose biopsy will give us some results. So if we do a PET CT guided biopsy, we will know that, okay, this is the active tumor and not the necrotic one. And so we can do a PET CT guided biopsy. Then if there is an unknown primary, the patient has presented with a metastasis like skeletal metastasis, a lesion in the leg, or any other bone, then we need to know where is the primary tumor. So PET CT gives you a whole body evaluation to look for where exactly the primary tumor is, which is giving this metastasis. Then there are so many malignancies in which, like in everyday practice as a standard of care, the PET CT is used. That is lymphomas, lung cancer, head and neck cancer, breast cancer, then GI malignancies like esophageal, GIST, colorectal, anal malignancies, genitourinary melanoma, and many, many more. Then carcinoma of unknown primary also. So these are the practice guidelines which are given by Society of Nuclear Medicine, and it was last given in 2013. So this gives us a fair idea as to where all the patient should be sent for the PET CT evaluation. So there are many times that the patients can be having a pulmonary nodule, not a full lung carcinoma, but just a solitary pulmonary nodule, which is indeterminate. So we don't know what it is, whether it is malignant or it is just a benign nodule. That can be evaluated by PET CT and see how much uptake is there of the FDG, and SUV values obviously will give an idea whether it is malignant or benign. Then staging of the lung cancer patients, and also for radiation therapy planning, determining the gross tumor volume. So this is one image of the PET CT. The patient is having CA lung. We can see that the lung is showing one lesion, and also there is one small paratracheal node which is there, which is actually small by the size criteria which the CT uses, but it is showing a very good uptake of FDG. It's looking very bright. Apart from the lung lesion, there is one small node which is looking quite bright. So it is showing a good SUV, and like SUV of 4, and then it is showing good uptake of FDG. That means that it is malignant. So for this patient, a mediastinoscopy was done, and the biopsy showed metastatic disease. So the disease was upstaged. So patient was known for having lymph node metastasis also. Then in lymphoma, pre-treatment and post-treatment, then in between for assessing the response to chemotherapy, routinely we are doing FDG PET CT in lymphoma. In this image, we can see, in the first image A, we can see that there is a large retroperitoneal mass. Then in the bone marrow also there is FDG uptake. Then axillary nodes also show uptake. Then in the image B, all that uptake has disappeared. That is after 6 cycles of chemotherapy, all the uptake has gone. So this is actually a complete metabolic response. So, but in the axial images, we can see that is the pre-therapy. C is showing pre-therapy where there is uptake, and D is showing that the morphological disease is still there, though it has decreased in size, but the retroperitoneal mass and nodes are still there, but it is decreased in size, and there is no uptake over there now. It is same as the background or blood pool uptake. So that, but still, according to the guidelines, it shows a complete metabolic response, and this patient remains disease-free. Then for esophageal cancer, again, initial staging can be done, restaging, treatment response, radiation therapy planning can be done. In this image, we can see that esophageal tumor is there at the gastroesophageal junction, and then a very small focal uptake is seen in the liver, which shows a metastasis. So this now becomes non-resectable because it is a metastatic disease, which is shown on PET, and this was not really much appreciated on the CT. Then colorectal cancer also, preoperative evaluation. Then in colorectal cancer, it is much more useful in telling us about the recurrence if the CEA level rises, which is the tumor marker for the colorectal cancer. Then coming to the head and neck cancers, the head and neck cancers present as many occult primary tumor cells, like they present as unknown primaries many times. They present as a metastatic disease like a cervical node, and then we need to find out where the tumor is. So the clinicians will send the patient to us for FDG PET-CT, and we may find out the primary which is there in the tongue or which is there in the buccal mucosa. So we find out where the primary is, and then the treatment is done. Then initial staging, then also after the treatment, residual disease can be seen. Then coming to breast cancer, which is very, very common in our population. So initial staging can be done where in a locally advanced or metastatic breast cancer. So initial staging only in locally advanced and metastatic breast cancer is recommended, and also for follow-up surveillance. So in this patient, we can see that both the breasts are showing uptake, and there are lesions in both the breast, but these are both resectable since there is no metastatic disease. So patient will go for surgery. And now in this patient, the spine, the vertebra is showing uptake. So it is having bone mets, that means bone metastasis is there. So this is inoperable, and patient will undergo chemo and local radiation therapy to the vertebra. Then coming to the cervical cancers, in cervical cancer also it is PET is extensively used for initial treatment planning, evaluating how much is the spread, residual or recurrent disease, then radiation treatment planning. Then melanoma, now we know melanoma affects the skin and the nodes, and as well as it can affect actually any organ. So then we need to know where all it has affected. The extranodal lesions particularly are picked up very well by the PET. So for the evaluation of extent of metastatic disease burden, initially or even in recurrent disease following treatment, we use FDG PET. Then post-treatment screening also we can use FDG PET. And coming to this image showing ovarian carcinoma. Now this patient has completed the treatment, and later on the tumor marker, which is CA-125, was rising, and the clinicians wanted to see where exactly the tumor is because the tumor marker is rising. So there we found out that there are pelvic nodes, para-aortic nodes, and also mesenteric deposit is there, where we can see the focal FDG uptake is there. Then also FDG PET can help in determining whether the patient is responding to treatment or not. The patient, this is a image of patient who was having unknown primary, but there was a lot of metastatic disease in liver and bones. Then there was a cycle of chemotherapy given, but then the disease after the chemotherapy increased. The liver lesions and skeletal lesions, everything increased. So, and SUV of the lesions also increased. So that means the patient is not responding to this chemotherapy regimen, and it needs to be changed. So the change in the chemotherapy is directed by the PET. Then we come to the non-oncological indications for PET-CT. Now, a very common indication is fever of unknown origin. When the patient is having fever for more than a month and we don't know where the infective focus is, it can be anywhere in the body. So we can come to know by using FDG PET-CT, since it's a whole body imaging. So in this patient, this was actually a CA tongue patient, cancer tongue patient, and who had a fever for a long time, and they could not find out where the infective focus was. And we did this scan, and here it is showing the infective focus in the veins, which is going from axillary, subclavian up to the internal jugular vein. So this is the area where the chemotherapy port was put. So this chemotherapy port got infected after numerous chemotherapies, and then the culture from here after this scan, they came to know that the chemotherapy port is infected, and so the culture from here gave the report of fungal Candida albicans, and then the patient got treated. So it is very useful in fever of unknown origin. Then we can see even in chronic infectious diseases like tuberculosis, we can assess treatment response. We can do a baseline scan as shown in the first image. We can see a supraclavicular and mediastinal nodes over there. And so after the ATT, after the anti-tuberculosis treatment, the uptake is totally disappeared. That means there is no residual disease and the response is very good. Then also in neurology, we can use F18-FDG for assessing dementia. It's a very common indication for which the patients come for FDG PET scan. When this the regional brain scan is done, not the whole body. So we see where all the metabolism is less. Those areas actually indicate the areas which are affected by this degeneration. So we can see hypometabolism, that is less metabolism in those regions. So we can assess whether the patient is having Alzheimer's dementia or frontotemporal dementia. Then also we can come to know if the patient is having epilepsy, where is the refractory focal seizure. So epilepsy which is not getting controlled by medications, that we can do an FDG and come to know where the epileptic focus is, and then the surgeons will go in and remove that particular area, and then the patient can be symptom free. Then in cardiology, it is used for telling the myocardial blood flow, that is perfusion imaging, and also viability. So here the first image is showing mismatch, that means perfusion. In the perfusion images, there is a defect in the metabolism. It shows FDG uptake. When the cells show FDG uptake, that means they are alive, they are viable. So with treatment, they will respond very nicely. Then the other image is showing a match, that means it's a scar. And so the cells of the myocardium over there are not alive, so the treatment will not really give much response. Then other inflammatory disorders like myocarditis, sarcoidosis, pericarditis and all can also be assessed by using FDG. But FDG, like apart from all these uses, it has some drawbacks also, which we should keep in mind. It has a limited resolution. This also depends on the machine actually. Then precision, there is limited precision because of the limited resolution. There can be physiological variations. Then some very well differentiated tumors like mucinous tumors and all may not be detected on F18-FDG. The cost may be high because cyclotrons need to generate these radionuclides. Then amount of radiation is there, which is actually small when you see that these many of these patients are cancer patients who already receive so much of radiation. But still, we need to have a judicial medical justification for each PET-CT referral. Then there can be some false positives like physiological FDG uptake, inflammation, infection, granulomatous diseases, then very small lesions, low cellular density tumors. Then for prostate and renal cancer, there can be low sensitivity. Then hyperglycemia. If the patient is diabetic, we really need to control the sugar. Otherwise, the scan will not show a good result. Then after FDG, we come to sodium fluoride, which assesses the skeletal system. So here, this is the evaluation of the skeletal system. This also has a whole lot of indications like oncologic and non-oncologic, mainly being the metastatic disease burden in the skeleton. Then the bone pain, primary bone tumors, then benign diseases like metabolic bone disease, and even infection. And in osteoid osteoma, the treatment response to radiofrequency ablation can be assessed. So this is an image of the patient with CA prostate. The PSA is very, very high. It is 335. And then the bone scan is showing multiple lesions, that you can say multiple dark areas. Those are the focal uptakes, which are multiple lesions of skeletal metastasis in this patient of CA prostate. Then here we can see this is a primary tumor of osteosarcoma. It's a bone tumor, so that's why it has a good uptake of F18 fluoride. And then also it is showing the uptake in the vein. So that is the femoral vein and extending up to inside the pelvis also. That is the thrombus. That is the tumor has spread till there inside the vein. It is the tumor thrombus. So, then after FDG and F18 fluoride, now we come to the other peptide receptor radionuclide imaging. The first one being the gallium dotatate. Now this is showing the SSTR expression, that is the somatostatin receptor expression. And here we can see this patient is having neuroendocrine tumor and many metastasis. So there are a lot of SSTR expressing metastatic disease lesions, which can be assessed by this gallium dotatate PET CT. So here we have injected gallium dotatate. So when we use gallium dotatate, we also have something called as lutetium dotatate, which is a therapeutic agent. So we can do therapy by lutetium dotatate, which is a beta emitter. Now by gallium dotatate, that is a positron emitter, we can do imaging. And the same with patient with lutetium dotatate, which is a beta emitter, we can do the treatment part. So that is called as theranostics, that they are assessing the same receptor, that is the SSTR receptor, but one is doing the diagnostic part, the other is doing the treatment part. So that is the therapy part. So this is called as a theranostic. Then coming to PSMA. Now, how we assess the neuroendocrine tumors using gallium dotatate? Same way we can assess the CA prostate using PSMA. PSMA is the prostate-specific membrane antigen, and it is a type 2 membrane glycoprotein. It is expressed many-fold in the prostate cancers. It is also expressed in the normal prostate, but multiple times more in the prostate cancer. So we can differentiate. And then same way as we have gallium PSMA for imaging, we have lutetium PSMA therapy in CA prostate, which can be used for treatment. Now this in this image, we can see a PSMA image of the patient with CA prostate, which is showing the primary prostate mass, which is infiltrating the urinary bladder. Then there is metastasis in the pelvic nodes, and there is also one solitary skeletal metastasis. So we can do the staging of the patient with prostate cancer. Then coming to recurrence. Now after the treatment, the patient comes back again. So we come to know whether there is a recurrence or not. Here we can see there is a recurrence in the prostatic mass. Then also metastatic inguinal nodes are there. Then even the pelvic nodes are there. In this patient, there is a testicular metastasis as well and skeletal metastasis. So we can see how the whole body survey helps us, and this PSMA is quite specific for CA prostate, but it is seen in other tumors as well. So we have to be very cautious and careful when we assess the CA prostate patients with gallium PSMA, because it can be seen in other tumors as well. Now, after all these radiopharmaceuticals, there have been some advances in the field of imaging technology also. So now we have earlier had PET CT. Now we have come to PET MRI also. So where the images of the PET and MRI are acquired in the same machine. Though it can be a little bit expensive, but it gives very good anatomical and functional information. So it is usually used in the brain tumors like lymphoma and gliomas. So in this image, we can see the primary CNS lymphoma, which shows a very good FDG uptake, as well as it can be appreciated on the MRI also. Then we know that this PET forms a molecular imaging, and we have come to this era of multimodality imaging, and artificial intelligence is also used in every field right now. So nuclear imaging is no less. Artificial imaging is being used here also. These are some few advances which are made using artificial imaging. Still in experimental phase though. So when we feed in the computer the normal scans, the computer comes to know that, okay, what is the uptake, what is the SUV in the normal liver, in the normal heart, in the normal spleen, in the normal intestines, or the normal lung. So it accumulates that data and it forms its own data set. And then after that, if we introduce it to any abnormal image, then it can find out that, okay, this is something abnormal, and it gives us the localization that, okay, here I have found a lesion. So that comprises the how artificial intelligence can help us in detecting the lesions. Then it also helps in classification. So because it has been fed, the computer has been fed with the SUV values of various lesions. So it can even tell us whether it is benign or malignant or which type it can be. So it gives us the classification as well. Artificial intelligence has come in a big way, and it is here to stay. So now I just want to say that if we image wisely with all these modalities available to us and all these radiopharmaceuticals available to us, we will definitely have happy patients and happy doctors. And thank you so much.
Thank you, ma'am. Very informative and knowledgeable presentation it was. Ma'am, I have a question from the participants. Shivani Thakur want to ask, PET is effective in locating pelvic recurrence of rectal cancer.
Pelvic recurrence of?
Ma'am, you.
Yeah.
Pelvic recurrence of rectal cancer.
Yeah. It is useful in finding out recurrence in any cancer. So in pelvic recurrence also, but physiological uptake may be there in the intestines, since it is there in the intestines, taken up in the intestinal mucosa also. But still we can find out because the SUV values will be quite high. So earlier 2.5 was taken as the cutoff, but then now it has been seen that there cannot be any specific cutoff. So any value which is more than the blood pool or which is more than the normal, then if we still have a doubt, we can do a delayed imaging. If we do a delayed imaging of that particular area, then we can see if there is any increase in the SUV. If there is any increase in the SUV value of that lesion, then it is most likely to be a recurrent lesion.
Okay, thank you, ma'am. Very well explained. Now, Ms. Divya Chauhan will take over the session.
Thank you.
Okay.
Thank you, Razia ma'am. Good morning to all of you. I, Divya Chauhan, Assistant Professor in Department of Radiology and Organizing Coordinator of this webinar. I welcome you all on behalf of Sri Guru Ram Rai University School of Paramedical Sciences. I am honored to invite our eminent speaker of the session, Dr. Pramod Kumar Gupta. Sir is PhD from Homi Bhabha National Institute, Mumbai, Maharashtra. Sir is currently working at the position of Scientific Officer E at Tuberculosis, Immunology and Immunoassay Development Section, RMC, Bhabha Atomic Research Center, Mumbai, host-directed therapeutic in tuberculosis. Sir has keen interest in research and teaching. Sir has published numerous research papers in national and international journals and also has present paper in various conferences and seminars. Now, I invite Dr. Pramod Kumar Gupta. Sir, you may please begin the session. Sir, please turn on your mic.
Thank you, Dr. Divya. And thank you, Dr. Lokesh, Dr. Divya, and Dr. Rawat for inviting me to speak in this webinar. Good afternoon to all the students, and I'll start my presentation. So today we are going to discuss about host-directed therapeutics in tuberculosis. So tuberculosis is still the most deadly infectious disease for the humankind, even in the era of COVID. So, even in the era of COVID. So if we go through the global scenario of tuberculosis, it affects almost 9 million new cases are added into the population every year, and which causes 2 to 3 million deaths per year worldwide. Out of these 9 million cases, 6 lakh cases are of co-infection of TB and HIV, and 4.5 lakh cases are with the and extremely devastating strains of tuberculosis. If we look at the Indian scenario, almost 40 to 45% of the Indian population is infected, and around 1.9 million new TB cases are added annually in India. So India is also known as the TB capital of the world. We have the highest load of TB, and out of these 40% population, or 1.9 million cases, up to 5% of the TB patients are HIV positive. So I'll take you through the little bit of chronology of tuberculosis. So tuberculosis, the causative agent of tuberculosis is Mycobacterium tuberculosis, and this bacteria has evolved along with the humans. So the proof of Mycobacterium tuberculosis can be found in the even Egyptian mummies and way before that. But the causative bacteria was first discovered by Robert Koch in 1882. So that time he described that tuberculosis is caused by a bacteria. And just before, now we are standing at the door of 2021, and just 100 years ago, in 1921, the vaccine for tuberculosis was discovered and BCG vaccination started. In 1940...
Excuse me, sir.
Yeah?
Excuse me, sir. Sir, आपकी presentation जो है, that is not visible. PPTs are not visible, sir.
PPTs are not visible.
Yes.
Oh, I started from that.
Yes, sir. Now it is visible.
Yeah.
Yes, sir. Thank you.
Yeah. So I'll repeat few points. So in 1882, Robert Koch discovered the tuberculosis bacteria, which is also known as Mycobacterium tuberculosis. And just 100 years ago, the vaccine for tuberculosis, that is called as Mycobacterium bovis BCG. So this vaccination was started. With the discovery of streptomycin and other antibiotics in 1940, the first line drugs for tuberculosis were discovered, and that time we thought that now we have overcome the tuberculosis. Now there is no means chance of having tuberculosis in future generations. But even in 2020, the global incidence of TB has increased, and it has increased rapidly in the last 2 decades, which can be attributed to a number of factors, including the first and foremost factor is failure of BCG vaccination. So this BCG vaccine confers protection only in the kids up to the age of 12 to 14 years, but it doesn't protect adults from the tuberculosis. The second point is emergence of drug-resistant strains of Mycobacterium tuberculosis. So you must be aware that antimicrobial resistance, or AMR, is the very severe threat in front of humanity. And if it is not taken care of in the time, then by 2050, it could be the deadliest pandemic that we'll face. And it will be even bigger than COVID, the current pandemic. So similarly, in case of tuberculosis also, because of the rampant use and reckless use of antibiotics, there is rapid emergence of drug-resistant strains. Third point is HIV pandemic. So in 80s, HIV was started, and HIV is a you can say that it suppresses your immune system, and when immune system is suppressed, then there is attack or there is development of active tuberculosis. The fourth point is weaker host immunity in in the societies which are economically poor, which has poor hygiene conditions. So now at this point of time when we are right in the middle of COVID pandemic, now I think everybody is aware about that how much important our immune system is, how the strong immune system can save you from so many deadly pathogens like COVID and tuberculosis. So before going into the main detail of my presentation, let us have a look of immunology of tuberculosis. So Mycobacterium tuberculosis is an intracellular pathogen which infects macrophages and dendritic cells. Now you know that macrophages and dendritic cells are the phagocytes. The phagocytes are the cells which has the power to kill the invading pathogens. But Mycobacterium tuberculosis is so smart that it doesn't get killed by the immune response of macrophages. On the contrary, it resides inside the macrophages and dendritic cells. So the host immune system is very critical factor both for containment and cure of Mycobacterium tuberculosis infection. Is there any doubt?
No, sir, you may carry on, sir.
Yeah. So let us see how immune system and which kind of immune responses are helpful for the control of tuberculosis. So these are, first is Th1 immune response. So if the Th1 immune response means, because Mycobacterium tuberculosis is an intracellular pathogen, so humoral immune response or type Th2 kind of immune response cannot be very useful in. Can you mute all the participants? Immune response of echoing. Just a second. Yeah. So I was telling that Th2 response or humoral response is not very helpful in case of in control of tuberculosis, because Mycobacterium tuberculosis reside inside the macrophages and antibodies cannot reach to the Mycobacterium tuberculosis. So for that reason, cell-mediated immune response or Th1 immune response is very important. Then activation of macrophages. Since Mycobacterium tuberculosis resides inside the macrophages, and macrophages, when these phagocytes they recognize any pathogen, then there is activation of macrophages. Activation means that the antimicrobicidal properties of macrophages are upregulated. So this activation can be of 2-3 types. It is M1 activation, M2 activation. So M1 kind of activation in which the antimicrobial property of macrophages are enhanced, that kind of activation is responsible for the clearance of or the containment of Mycobacterium tuberculosis. Third is nitric oxide production. So nitric oxide is kind of free radical, and it is very responsible for clearance of or killing of any intracellular pathogen inside the phagocytes. Then fourth is phagosome-lysosome fusion. So you know that when there is any kind of phagocytosis, it means when these phagocytes recognize any pathogen, then they engulf these pathogens, and intracellular structure called as phagosome is formed. Now these phagosomes are matured. Matured means gradually the pH of these phagosomes starts decreasing, and after some time it fuses with the lysosome. The pH of lysosome is around 4 in the range of 4 to 4.5. So at that pH, all the cytolytic or proteolytic enzymes are activated, and any cargo which is delivered by the phagosomes to lysosomes will be cleared and will be killed. Fifth point is induction of apoptosis and autophagy. So apoptosis and autophagy are kind of cell death or programmed cell death, and these pathways are they play a very important role in the clearance of Mycobacterium tuberculosis from the macrophages and dendritic cells. So if we have so many immune response in the macrophages or in our immune system, then why active tuberculosis develops? So active tuberculosis develops because Mycobacterium tuberculosis has many virulence factors. So these virulence factors are able to suppress these immune responses. So it causes the perturbation of host immune response, and that is how active tuberculosis develops. So if you have a strong immune response or a strong immune system, then there are chances that even if you are infected with tuberculosis, Mycobacterium tuberculosis, you will not get the active disease. So in that case, this kind of disease is called as latent tuberculosis, in which you will not show any symptoms. So the person can remain asymptomatic for lifetime. So I have given 2-3 examples that how Mycobacterium tuberculosis virulence factors, they disrupt or they target the host immune system for their suppression. So if you are aware about how the cytokines are secreted or how the effector mechanism of macrophages takes place. So there are two kind of signaling mechanisms. One is MAP kinase signaling and JAK state signaling. So these signaling molecules are very much important, and their downstream effector molecules are very much important for the secretion of cytokines. So when mycobacteria enters or it is recognized by the macrophages, the virulence factors secreted by mycobacteria, they attack on these pathways and they inhibit these pathways, and thereby thereby they inhibit or suppress these two pathways, and ultimately it leads to the less secretion or suppression of the production of cytokines, which are responsible for the macrophage activation and T cell activation, or you can say the immune activation. Similarly, in case of dendritic cells, so dendritic cells or any phagocytes, how they recognize the pathogen. So they recognize the pathogen through a receptor which is expressed on their surface, which is called as pattern recognition receptor, PRR. So PRRs are the receptors which recognize some molecular patterns in the cell structure of pathogens. So these cell structure of pathogens are called as pathogen associated molecular patterns, or PAMs. These PAMs are recognized by the PRRs. So this TLR is an example of PRR. So it has the binding domains which can recognize certain molecular structures which are present on the Mycobacterium tuberculosis or any other bacteria's surface. So they have very important role to play in the activation of dendritic cells or any phagocytes. So here you can see that if the Mycobacterium tuberculosis or any bacteria is recognized by TLR, then after the downstream signal processing, there will be activation of NF-kappa B and overexpression of IL-12, TNF-alpha and nitric oxide, or it means that there will be a proper activation of dendritic cells. Now dendritic cells are the most important antigen presenting cells. So these dendritic cells, activated dendritic cells, they will present the mycobacterial antigens to T cells, which will lead to activation of T cells. So if in nutshell we can say that dendritic cell is activated properly, then it will activate T cell and there will be optimum immune activation. But there is another surface molecule on the surface of DCs which is called as DC sign. So if Mycobacterium tuberculosis is recognized through DC sign, then there will be inhibition of this process and dendritic cells will not get activated, and ultimately it will lead to the inhibition of T cell response. Excuse me. So, how dendritic cells or how these cells recognize that when means when to use TLR, or when the Mycobacterium tuberculosis will be recognized by TLR and when it will be recognized by DC sign. So Mycobacterium tuberculosis or any bacteria, they have, you must be aware that their cell wall has some structure which is called as lipoarabinomannan, LAM. So LAM has 2-3 kind of polysaccharide capping. So if LAM has capping of arabinose, which is called as aralam, and it can also have capping of mannose, then it will be called as manlam. So in the avirulent strains of tuberculosis, this aralam is found. If there is aralam, then this aralam, arabinose capped lam, will be recognized by TLR. But in the case of virulent MTB, there will be capping of mannose lam. So mannose lam is exclusively recognized by DC sign. So if it is recognized by DC sign, means virulent strains of TB will inhibit the activation of dendritic cells. Similarly, the attenuated MTB or avirulent MTB, if it is infecting the macrophage will undergo apoptosis. Apoptosis is kind of clean death, and then apoptotic vesicles which are formed, they will be taken up by the dendritic cells and presented to the CD4 and CD8 T cells, which will lead to the activation of T cells. But if the mycobacterium is virulent, then due to the virulence factors, the apoptosis will be inhibited, and there will be induction of necrosis. Now necrosis is known as dirty death because the contents of necrotic cells are means they will affect the neighboring cells. So it will the mycobacteria which is present inside the necrotic cell, that will infect other macrophages also. So this is not a favorable response for clearance of mycobacteria through the macrophages. Apart from this, so it was all about the host pathways which are responsible for the clearance of Mycobacterium tuberculosis. Now the second thing, many people ask us that why do you work on tuberculosis? Otherwise, in all the public transport, behind all the autos, it is written that dots khao TB dur bhagao. But what is the reason that still after having a vaccine for 100 years, what is the need to work on tuberculosis? So the need is emergence of drug-resistant strains of TB. So we have many antibiotics, first line, second line, but these drugs are not working. And when these drugs are not working, then we have very limited treatment options to kill the TB and to save the person. So it is increasing the mortality, which is anyway it is higher than many pathogens. So what is the root cause of this emergence of drug resistance? So the first is these anti-TB drugs have severe side effects. Because of the side effects of this current drug regimen, people tend to skip the doses when their symptoms is relieved. Then second point is the treatment duration is long. It can go from 6 months to 18 months. So that also forces the people to skip the doses. So these two things causes non-compliance of the medications, and which is the main cause for the emergence of drug resistance in Mycobacterium tuberculosis. Third is treatment is very complex. It requires longer use of more expensive, less effective and toxic anti-TB drugs, which result in high morbidity and mortality. And fourth is failure of healthcare system. So the real or the ideal scenario is that when any patient goes to a healthcare system, then first thing should be to check the drug resistance. But in many places in India, doctors, they start directly with the first line of treatment without knowing that whether this bacteria is resistant to first line or what. So that is also one of the main contributing factors for emergence of TB. So now, okay, and after 40 years of discovery of first line and second line drugs, 40 to 50 years, last, I think 3 years back, one new antibiotic was discovered or approved by FDA for treatment of tuberculosis. The name was bedaquiline. But just after 1 year of treatment use, now we have Mycobacterium tuberculosis strains which are bedaquiline resistant. So what happens then when you discover any antibiotic? In that case, these pathogens are small organisms. So their crucial pathways are targeted, which are controlled by a single gene. So when you are targeting a pathogen and we are targeting a single gene, then there are chances that after certain time of certain duration of treatment, these Mycobacterium tuberculosis or any bacterial pathogen, they will evolve and they will have mutation against that gene, in that gene, which is responsible for the, or which is the target of that antibiotic. So that leads to a rapid emergence for resistant against that antibiotic. So if you, means we have bedaquiline, we have second line, we have first line, but still we have very limited options. So now, can we think of something other treatment modality which can be little bit means there are less chances of development of drug resistance? So is any immunomodulator which can target the immune system could be an alternative treatment? So before going into the immunomodulator, just the about the definition of immunomodulator, it is an agent that augments or diminishes the immune responses. It could be anything: cytokines, pharmaceuticals, microbial products, and traditional medicinal plants. So why immunomodulators in tuberculosis? Because I discussed that how the immune system is able to contain and control the TB if the immune system is not suppressed or not perturbed by the virulence factors. So these immunomodulators have the ability to strengthen the host immunity, stronger the host immunity, and properly evoked immune response may make the host capable of successfully combating and hindering the intracellular survival of pathogen. Unlike antibiotics, immunomodulators target the host rather than the pathogens, and therefore this kind of treatment modality remains impervious to the evolution of any drug resistance. So these immunomodulators are the molecules which target host pathways, and by targeting the host pathways, if you can cure some diseases, especially infectious diseases, then this kind of therapeutics or these molecules are called as host-directed therapeutics because they are targeting the host rather than the pathogen. So most of the host-directed therapeutics fall under the category of TLR agonist. TLR agonist means the molecules which can activate various TLRs. TLRs are PRRs, just now we discussed. So host-directed therapeutics are mainly being used for the treatment of many viral diseases. And in case of tuberculosis, it is an emerging concept, and many groups are working to discover many TLR agonists or host-directed therapeutic molecules for the treatment of tuberculosis. So this is the example that, like imikimod, it is a TLR7 agonist, and it is under clinical trial for the treatment of HPV-associated genital warts. Then MPL is a TLR4 agonist. So then we have TAK242E5564. So these are all TLR4 agonist and antagonist, and they are being used for the treatment of sepsis or septic shock. So the objectives of immunomodulation in tuberculosis is potentiating the host immune response for the better control of TB, strengthening the patient's native immunity, negating the biological effects of the bacilli on the host by inducing the production of beneficial cytokines and amplifying their positive effects, and establishing the host homeostasis between Th1 cell-mediated immunity, and TS2 humoral responses. So the major goals for SDTs in TB is they can be used as the adjuncts to the antibiotics. I would like to make this point clear that SDTs alone cannot cure from infectious diseases. There has to be a support from antibiotic regimens, but they can be obviously used as adjunct to the antibiotics. So they can decrease the IC50 value of antibiotics, they can decrease the treatment duration, and they can affect the TB outcomes. They can reduce the TB recurrence, and they can enhance the efficacy of current drugs in MDR and XDR. It means that if some antibiotic is not working against, or it IC50 value is increased, it is not killing the MDR TB or XDR TB. In that case, if you are using any SDT molecule, then there are chances that same antibiotic can be used at lower doses, and it can be useful in clearance of MDR and XDR TB. Further, TB is associated with lung damage. So with the use of SDTs, the pulmonary impairment after TB can be reduced. And the most important part is that unlike antibiotics, this approach is very less likely to lead to development of AMR or antibiotic resistance. So these are some candidate pathways. So here you can see that, means I have discussed it already. That's Mycobacterium tuberculosis. It is getting phagocytosed. After phagocytosis, there is a lysosome-phagosome fusion, but because of the Mann-Lamb, this phagosome-lysosome fusion is inhibited. So these candidate pathway can be targeted by the host-directed therapeutics to kill Mycobacterium tuberculosis or to cure TB patients. These are certain examples like imatinib, vitamin D, silostazole. These are certain host-directed molecules which are already FDA approved for other diseases, but they have been repurposed to treat TB patients, and they are in the treatment regimen along with the standard antibiotic regimen. So in host-directed therapeutics, what we are doing at RMC, so these are certain works that we I'll present few data from our group. So we have worked on a molecule which is a polysaccharide from Tinospora cardifolia. The name is G148. So we have proved that it inhibits the survival of Mycobacterium tuberculosis by modulating host immune responses in TLR4 dependent manner, and it is active against drug sensitive as well as drug resistant tuberculosis strains. Similarly, we have reported that the most common herb and its ingredient curcumin. So we have, first of all, we have reported that it inhibits the intracellular survival of multi-drug resistant clinical isolates of MTB in macrophages by curcumin. So these two drugs we have mainly worked upon, and I'll be presenting a little bit of summary of this work. So first of all, G148. This is the mechanism of action of G148. So G148 is a TLR4 agonist. It binds with TLR4. From TLR4, the downstream molecule is MYD88. So it activates the MYD88. MYD88 activates MAP kinases. From MAP kinases, there is activation of NF-kappa B. NF-kappa B activation leads to production of inflammatory cytokines and expression of MSC2 and CD86, production of nitric oxide. So nitric oxide is a antimicrobial molecule which kills the intracellular pathogens. Cytokines are required for the proper activation of T cells, and MSC2 and CD86 are required for antigen processing and presentation to the T cells. So this is the mechanism of action of G148 in macrophages. So we concluded that G148 activates murine macrophages through classical activation, classical activation is also known as M1 activation. So we concluded that this molecule acts at the level of macrophage activation and it confers M1 activation in macrophages. This G1/4A mediated macrophage activation is TLR4 MOID88 dependent, and it activates P38, ERK, JNK MAP kinases. These are the three MAP kinase pathways. So these are activated by G1/4A, and which leads to the activation of macrophages. After that, we check this compound, this molecule in vivo model of tuberculosis. And so in vivo model of tuberculosis was we infected bulb C mice, and we found that it increases the production of nitric oxide in MTB infected macrophages by upregulation of NOS2. Oh, sorry, this is about the cell line or cell data that I was discussing. So after that, we did some in vivo experiments, and in animal model, we found that we infected the bulb C mice with Mycobacterium tuberculosis through inhalation route, because that is the most common route through which humans get the infection. And we found that there is upregulation of TNF-alpha, IF and gamma, NOS2 in mice lung. There is upregulation of TNF-alpha, IF and gamma, IL-6, IL-12 in serum, and decrease or downregulation of IL-4 and IL-10. So here, I like to mention one point, that IL-2, IF and gamma, these are cytokines which fall under the category of Th1 cytokines. So if there is expression of these cytokines, it means that it is leading to Th1 immune response. Whereas when IL-4 or IL-10, they are overexpressed, it means there is dominance of Th2 immune response. So here you can see clearly that there is upregulation of Th1 cytokines, whereas downregulation of Th2 cytokines. And by IF and gamma IL-4 ratio, we concluded that okay, it is causing Th1 activation in mice. And simultaneously, it was the treatment of this compound was decreasing the mycobacterial tuberculosis load in the infected animals. So we concluded that G1/4A reduces the bacilli burden in lungs of bulb C mice. G1/4A along with the INH is a isoniazid. So we did one experiment where we treated the animals with G1/4A along with isoniazid. Isoniazid is a standard antibiotic which is used for the treatment of tuberculosis. And we found that this combination offered better protection, which suggested that G1/4A can be used as adjuvant to the current antibiotic regimen. And we found that there is induction of Th1 immune response in MTB infected mice by G1/4A, and this could be responsible for the protection offered by G1/4A in animal models. Then in case of our curcumin studies, as I discussed earlier, that phagosome-lysosome fusion is one of the most crucial pathways. So for that, what we did, we used GFP-labeled mycobacteria, which is green rod-shaped structure is GFP-labeled mycobacteria, and we labeled the phagosomes with a red color, lysotracher red. This blue color, you can see it is a nucleus, and we treated the cells with different doses of curcumin, and we tried to find out whether these phagosomes and lysosome are fusing. So this green color means this is the mycobacteria which is inside the phagosome. This is a excuse me. This is the red color shows presence of liposome, and if red and green fuses, then it should produce yellow color. So here you can see that at the concentration of 10, there is you can see this yellow color. It means there is, or even at this concentration, you can see the yellow dots. These yellow dots represent that because of the treatment with curcumin, there is upregulation in the fusion of phagosome lysosomes. As if you compare this with the untreated cells, you can see here that there is no phagosome lysosome fusion. So it means that this compound was working through the phagosome-lysosome fusion. Then we, because curcumin has some bioavailability issues, it is lipophilic, so it is not very easily bioavailable in the human serum. So to overcome that, we made some nanoparticles, and in nanoparticles you can see here that there is a huge uptake, and the bioavailability of these nanoparticles was increased by 3 to 4 folds as compared to curcumin. So we concluded here that curcumin induces autophagy. Autophagy and apoptosis data I didn't include in the slide, but we concluded that curcumin induces autophagy and apoptosis in MTB-infected macrophages. And this autophagy, which is mediated by curcumin, is the main effector mechanism in this case, and it is involved in the clearance of intracellular MTB. This curcumin treatment induces phagosome-lysosome fusion in MTB-infected macrophages, and the bioavailability of nanocurcumin is enhanced significantly. And this novel approach of force-directed therapy can be explored for the adjunct therapy in tuberculosis. So this is all about SDTs. Thank you. If you have any questions.
Thank you, sir. This session is very informative. And sir, we want to hear you again and again in future. Students, if you have any question, you can ask or inbox us.
Sir, there is one question. It has been asked by one student, that is Rohit Shukla. He has asked, it has been widely discussed that tuberculosis vaccine BCG offers a protection in COVID-19. However, it fails to confer protection against TB in adults. Why?
So the reason is, I'll first answer why it doesn't protect adults from tuberculosis. So what happens that the protection by any vaccine, it depends on the production of long-lived memory T cells. So it has been seen that in case of tuberculosis and in case of BCG vaccine, the BCG vaccination does not produce very long-lasting T memory cells. So the life of this T memory cell is in the range of 10 to 12 years, and there are some limitations by which we cannot give booster doses of BCG. So that is why it fails to protect the adults. It can offer protection up to the age of 12 to 14 years. Now the second part, it offers protection, means there are some ecological data, and it is strongly believed that because in India or in many countries where BCG is part of universal vaccination program, so BCG is a mycobacteria. Mycobacteria have many TLR agonists, and by virtue of that, it is also a live vaccine, and it is given to all age groups, like means infants, adults, elderly people. So when it is injected inside the body, it is taken up by the macrophage dendritic cells, and it induces a novel phenomena which is called as innate memory response. Generally, you know that memory response is the hallmark of adaptive immune system, but BCG vaccination induces trained immunity. Trained immunity means innate memory response. So by induction of trained immunity, which is very broad in nature, the macrophages are in activated state, so they can kill any kind of bacteria or any pathogen, and it is reported that because of the BCG vaccination, means it doesn't only protect from COVID, it can protect you, it protects the kids from many respiratory infections. So that is the reason why it can offer protection in case of COVID also.
Okay, thank you, sir. So there is one more question asked by Aarti Bisht. She has asked, are immunomodulatory drugs safe? Is there any side effects?
Yeah, immunomodulatory drugs, like any other drug, can have side effects. So without having means all the clinical trials and safety studies, we cannot use immunomodulators for treatment of tuberculosis.
Okay. Sir, there is also a question asked by Shivani Thakur. What is multi-drug resistant tuberculosis?
Multi-drug resistant tuberculosis, as per WHO definition, if any means Mycobacterium tuberculosis is resistant to isoniazid and rifampicin. These are two first-line drugs. So if it is resistant to these two drugs, then that strain will fall under category of MDR strain.
Okay, sir, there are some other questions also. Sir, what is diagnosis and treatment for the latent tuberculosis infection?
So for latent TB, the gold standard diagnosis is IGRA, interferon gamma release assay. So that can be done, but generally because latent TB doesn't show any symptoms, so unnecessarily people do not go for diagnosis. And treatment, isoniazid and rifampicin. Isoniazid can be given for 12 months as per the WHO regimen, but still means if you ask me individually, that is not the right approach, because you don't know that the latent TB which is sitting inside the macrophage, whether it is resistant or it is sensitive. If it is isoniazid sensitive, then isoniazid will work. If it is not sensitive, then it will not work. So there is no need to treat latent tuberculosis.
Okay, sir. Sir, another question is, how much is the effectiveness of combined drug therapy for HIV and TB?
Combined drug therapy, which drugs?
Sir, she has only mentioned how much is the effectiveness of combined drug therapy for HIV and TB. She has not mentioned any drugs.
Yeah, if she can elaborate, then I can answer.
Okay, okay, sir. Thank you so much, sir.
Dr. Neha, can I ask something to?
Yes, sir, please.
Yeah. Hello, Pramod. I hope you are doing well. It's good to see you after a long time.
Yeah.
Sir, I just have a question. Like, see, we are targeting multiple pathways, multiple immunomodulatory pathways for taking out a drug, identifying a certain drug for tuberculosis, fighting against tuberculosis. Be it NF-kappa pathway, be it some NRF2 pathway, be it any other TLR4 pathway. So, what, in your perspective, with your experience, can we identify 3 most putative targets that can be specifically inhibited in combating the tuberculosis or in combating the multi-drug resistance?
Means you are talking about only TLR agonist, or you are talking about in general any specific?
In general, if we go for screening, then maybe a few top 3 that has been more potent in augmenting this particular tuberculosis.
So from my experience, I can say that the molecules which target phagosome lysosome fusion, because that is the most crucial experiment. By inhibiting this pathway, actually Mycobacterium tuberculosis is able to survive inside macrophages. So if we target phagosome lysosome fusion pathway, then that will be great. Then the alternative pathway of delivering the phagosomal cargo to the lysosomes could be induction of autophagy. So if you target autophagy, and if you can induce autophagy by some therapeutic molecules, then that can overcome the phagosome lysosome fusion inhibition imparted by MTP, because that autophagosomes can directly deliver the cargo to the lysosomes. So from my experience, these are 2 pathways which should be targeted.
Okay, thank you, sir. I think Dr. Neha, you can proceed with the session.
Okay, sir.
Thank you, sir. Now I invite Mukesh Chamoli, sir, organizing secretary of the webinar, for vote of thanks.
Thank you, Diba ma'am. I, Mukesh Chamoli, organizing secretary of the webinar, would like to thank our Honorable Chancellor, Sir, Sri Mahendra Devendra Das Ji Maharaj, for his continuous blessing and support. I would like also to thank Honorable Vice Chancellor, Sir, for his benign presence and sharing his eminence to the participant. Now, I pay my thanks to the convener, Dr. Lokesh Gambhir, College of Paramedical Sciences. Constant support has led to the well excitation of the webinar. I sincere thanks to all the speakers for their valuable, informative, and knowledgeable session that will seriously upgrade the better understanding of the topic to our students. Now, I special thanks to Dr. Neha Chauhan, co-convener of the webinar, for her sincere efforts and managing skills. Ma'am has taken keen interest in the activities and motivated us throughout. I am happy to express my gratitude to the organization coordinator, Ms. Rajya Siddiqui, and Ms. Divya Chauhan, who has constant dedication toward the webinar and made and success.
Now I invite Dr. Lokesh Gambhir, Dean Paramedical and convener of the webinar, for official closing of the event. Sir, please.
Thank you, Divya ma'am. Thank you. Though it's a small word, but it is wrapped with sincere gratitude that we at School of Paramedical Sciences, SGRR University, are feeling at this moment. I extend my profound gratitude to the Honorable Chancellor, sir, for his continuous encouragement and support. I extend my humble gratitude to Honorable Vice Chancellor, sir, for taking out time from his schedule, gracing the webinar with his benign presence, and enlightening the session with words of wisdom. My sincere thanks to Academic Coordinator, SGRR University, Dr. Malvika Sati ma'am, for taking out time from her busy schedule and gracing the occasion. A heartfelt thank you to express my sincere gratitude extended to our keynote speakers, Dr. Priyanka Baba ma'am and Dr. Pramod Gupta, sir, for accepting our invitation. Thank you so much, ma'am, for taking out time from your busy schedule. I understand that it's Friday and you are already occupied in the hospital. So is Pramod, sir. But it's really generous of you to take out the time. And we at School of Paramedical Science really appreciate your time and your talk. Pramod, sir, again, thank you so much. It was wonderful to have you and to see you after a very long time. Although nothing has changed much, but yes, it was a pleasure indeed. See, the team effort, it's a team effort that made this webinar a huge success. I thank the entire team of School of Paramedical Sciences, co-convener Dr. Neha Chauhan, organizing secretary Mr. Mukesh Chamoli, organizing coordinators Mrs. Divya Chauhan and Ms. Radhya Siddiqui for their enthusiasm, diligent efforts, and crisp execution of the webinar. My special thanks to the IT team of the SGRR University, Mr. Sudhanshu ji, Mr. Ashwini, who is here with me right now and managing everything, the technical aspect of the webinar, Mr. Vinod, Mr. Gaurav Farasi for providing technical support, the team behind the scene, Mr. Kamal, Ms. Neha, Ms. Sapna, and Jay Prakash for their. Last, my sincere respected dignitaries and who joined us in making this webinar a success. I hope the webinar was informative and with the area of your interest. With these words and a promise to keep our efforts in apprising you all with many informative sessions like this in future, I, on behalf of the organizing team, officially declare the end of a fruitful session in form of webinar. Thank you so much. Thank you all and have a great new year 2021. I hope the 2020 repeat will not be there and the coming year will be a fruitful one for all of us. Thank you so much. Thank you all. Thank you, Dr. Priyanka. Thank you, Dr. Pramod. Thank you so much.